I would now like to hand over to the Honourable Minister for Health, Pak Budi Gunadi Sadikin, who unfortunately isn't able to join us in person, but who is going to welcome us online from his office in Jakarta. Pak Budi.
Yeah, thank you. Can you all hear me? Okay, ladies and gentlemen, good evening. And my deepest apology that I couldn't join you in person in Bali, but welcome in Bali, Indonesia. And thank you for improving the Indonesian economic condition by spending your money in Bali. So, ladies and gentlemen, when I joined by the end of 2020, my job on the first 18 months is just to handle COVID. But then after that, in July 2022, I started to work really as a health minister. And the first information that I received, Indonesia universal health coverage is excellent because we have our national insurance scheme is already covering 280 million members. Then I checked at WHO health coverage index, and I realized that Indonesian positions is number 55. So I'm quite surprised when I see the stark differences between the definition of Indonesian universal health coverage and why we are ranked, I think, the bottom 20% in WHO. And then I realized that, universal health coverage is not only right to access or you having card that you are a member of a national insurance scheme, but it is to ensure that all people have access of full range health services when and where they need them without financial hardship. And I just realized while Indonesian national insurance system provides you with the right to access, but the people cannot actually access because we don't have enough hospitals, we don't have enough medical devices, and we don't have enough doctors. So it is only the card, but it is not the real access. So that's why to improve these conditions in second semester 2022, then we come up with this 6 pillar of Indonesian healthcare reform. And we have defined 6 core transformational strategies, and I would like to touch on the first, the second, and the fourth one. The first one is very close to my heart, is the reform in primary care. Indonesia have 34 provinces, 514 cities, 7,000 plus 2,000 districts and 85,000 villages. We only have our offices at the district level, 10,000, we call it puskesmas. And then in the new law that we drafted to support this reform, we expand our coverage formally to 85,000 villages. So now instead of 10,000 districts and 7,000 inhabited island, our network of healthcare services will reach 85,000 villages. The second reform that we do in primary care is we revitalizing them. Revitalizing them, means that we digitalizing them fully. We put massive programs, like example, increase the vaccination coverage, do very massive screening programs, and reform also the promotive programs in the puskesmas. And we also do, for the first time, developing the national public health laboratory networks, which is we don't have before. And during COVID, it hits us strongly. So those are the primary initiative that we are doing in our primary care reform. I give you one example of one of the biggest ever program that we run for our primary care network. We run this program back in the 10th of February this year, which is the mandatory screening program for 280 million Indonesian people every year. So the newborn screening, the below 5, the elderly and adult and elderly, and the next slide, it will be for school children. So elementary school, junior high school, and senior high school. That's including mental health also, that we never checked before. So this most ambitious and massive, screening program to the whole population on yearly basis is run since this year, and hopefully by the fourth year we can cover 280 million of Indonesian people. And as a result, after you get the screening, we will send them WhatsApp messages that show you the summary of your health conditions. Whether your blood pressure is yellow means between 90 to 140, red is above 140 and 90, or it's green. And also blood sugar, your kidney conditions, eyes, ears, etc. And you click into each of them, you can get the detailed explanations of them, including an AI advice. Like if you run Strava, there's an AI advice on it. And then if you click, you can get a QR code and you can come to the primary healthcare clinics, 10,000 that we have, to get a free subscriptions. For example, if you have high blood pressure, then you can get a free amlodipine. If you have a high blood sugar, then you can get a free metformin. So on the next slide, and this is the result so far. We have able to reach 14 million Indonesian people since the launch on the 10th of February, with a daily running rate of screening of 200,000 niche people, which is around 5 million every month. So hopefully our target to achieve 50 million Indonesian people screened this year can be achieved. And next year we will increase to 100 million every year, and the year after that 150 million every year. So hopefully on the fifth year we will be able to screen 250 million plus Indonesian people every year and record the data and to do preventive actions on their diseases. And thank you for World Bank to equip this one. We managed to structure a $4 billion loan syndicated from World Bank, AIIB, Asian Development Bank, and Islamic Development Bank, signed by the end of 2023. And now we start deploying a massive, instruments, medical devices at 10,000 puskesmas, and also building 514 public health labs. So hopefully in the next 3 years, all 10,000 puskesmas and 514 public health labs will have 110,000 new instruments funded by the syndication of World Bank on these devices, so we can support the massive, ambitious screening programs that we will have in this country. On the next slide, I will update you on the second pillar of reform, which is the secondary care transformations. When you got sick, hopefully you don't get sick, then what we will do to improve that. And on the next slide, you can see the condition. I give you an example. Pak Hasbullah, can you mute your screen because you are... Okay, so on this secondary pillar reforms, we realized that we don't have enough healthcare facilities, both in terms of instruments and also in terms of human resources to serve our people. I give you an example. Number one killer in our country is stroke, 300,000 every year. Number two is heart attack, 250,000 a year. And I was advised, but stroke, you have a golden period of 2 hours, and heart attack between 6 hours. So that's why we make a decision, let's have the facility to take care of stroke and also heart attack at the city's level. Because, like example, if you get a stroke in Los Angeles, you cannot bring that person to San Francisco, right? Or you get stroke in Washington, D.C., you cannot bring them to New York. You need to handle in that same city. So that is the same logic that we have. And I just realized in July 2022, out of 514 cities that we have, only 44, less than 10% of Indonesian cities have the capability to handle stroke and heart attack. Even out of the 34 provinces or states that we have, 6 of them cannot handle strokes and heart attack. So I give you an example. We have a very large provinces in Maluku. The capital of these provinces or state is Ambon. When you got stroke there, or heart attack, they don't have cath lab facility. So what we can do is fly them to Makassar or Manado and hope they will live. So that is how bad our infrastructure is. So that's why, again, with the support of World Bank, ISDB, ADB, and AIIB, we managed to procure a large number of medical devices, 514 CT scan, 514 mammogram, 514 immunohistochemistry lab, 514, cath labs, 34 Linacs, 34 brachytherapies. All those expensive machines that we will distribute it to 514 cities and 34 provinces so we can handle this one. So you can see in the map, this is 1.5 years after we start the initiative. Before it's only 44. Now I review this every bi-weekly, and now the position is 112. 112 out of 514 cities. When you get stroke, there is a CT scan that can scan you, and there is a cath lab if you need a thrombectomy. So this is the progress, and hopefully by the end of 2027, we will be ready with 514 cities. Many people told us it is very ambitious, this is a very dream project, nobody can do it. But we proved that we can increase by more than 70 cities in 1.5 years. So we have an ambition that we will increase it to 514 cities. Next slide, I give you an example of the bypass. This is more difficult if you have a heart attack. Instead of put PCI intervention, a lot of Indonesians have a heart attack that you need a bypass. When I joined, there are only 9 provinces can do bypass. So again, many people, the queue is very long, people are dying, so access to healthcare services is close to none, especially when you are living outside of Java. On the next slide, by this year, I just opened, now increased from 12 to 25 provinces that can do CABG procedures or open heart surgery bypass. And it is our intention by the end of next year, it can reach 30 provinces. So all Indonesians in all provinces, they have the same right to access these complicated procedures to save their lives. So next slide. And again, with the help of World Bank, these are some, it's not all, but this is some of the devices that we buy and distributed across the country. I have a funny story about PET scan. It's not, because PET scan, we have a lot of cancer, 234,000 deaths. Number of cities that have PET scan is only one in Indonesia. Can you imagine, like you are live in United States, if you want to look for PET scan services, you have to go to New York. Outside of New York, there is no cities that can provide PET scan facility. So when I joined, that is the condition. Now we already increased to 4 cities. Hopefully by the end of 2037, we will complete with 34 cities across the provinces will have the PET scan facilities. Next slide. The problem with after the devices is the people. We lag by extremely far in terms of number of doctors and specialists. So you can see the red one. If you need a heart intervention to do PCI, you need a cardiologist with interventional skill. Stroke is the same thing. You need a neurologist with intervention subspecialty. Cancer, you need a chemotherapist, medical oncologist, and endocrinologist. And you can see there's a huge gap. Available like medical oncologists, you have 88, we need 482. So this is the fact that by far we are behind so much, and many of our people die because we don't have enough doctors. Next slide. So when you want to increase this drastically, the problem is we don't have enough seats. Even the number of faculty is too small, and we would like to increase, it will take us 20 years. To provide with all doctors. And can you imagine, 300,000 people die, you have to wait for 20 years. So what we do, then we opening up, change the regulations so people graduate from outside can getting in. And also we can send our people outside of Indonesia to the country that open up for our fellowship training. And once they finish, they can do the procedure as this and compensated fairly as the specialist that is graduate from inside the country. Next slide. So we work with the government of India and China. And these are, we are sent close to 100 people already, and hopefully fellowship programs in India and China, Japan also, most likely Korea will come very, very soon. And these doctors will come back to Indonesia very, very soon. And when the devices are ready, when the cath labs are ready, when the chemotherapy facilities are ready, when the LINAC are ready. So this is to accelerate the huge gap that we have in the human resources. Next slide. Now, the last one is about health financing, which is the interest to all of you. This is my worry as a banker. I'm not a medical doctor. I don't have any medical background. I'm a nuclear physicist by training. But when I see these numbers, I feel very scared. You know, ladies and gentlemen, before Indonesia only do the national health account every 2 or 3 years, and we estimate in between. Since 2020, when I came, with the help of World Bank, we did every year, because I want to know how much do we spend every year, the country as a whole. And for your information, we are spending about 40 billion US dollar per annum. If you divide by 280 million Indonesian, on the average, Indonesians spend around 140 US dollar per person per annum. And for that spending, we reach 72 years average life. Now, my problem with this chart, I have 3 problems. The first problem, these numbers are big. These numbers are big and increase between 11 to 13% annually. So 40 billion are big and increase 11 to 13% annually. And the potential in the future even bigger. Because when I compare to Malaysia, our closest neighbor, the average life is 76. We are 72. The average spending per capita in Malaysia is 430. We are 140. So 300 US difference. Now, ladies and gentlemen, I'm 62. I'm still running marathon. So I believe that Indonesian population will be aging. And if they are aging and reach Malaysian level in the next 5 or 10 years, logically, our healthcare spending will increase, at least at the Malaysian level, if our healthcare system as efficient as Malaysia, which is we are not. But assuming we are aging in the next 5 to 10 years, reaching Malaysian level, 76 instead of 72, and then our spending will increase by 300 US per capita. You multiply by 280 million Indonesians, that will be 84 billion US dollars. Double, or that will be triple the amount that we spent this year. So this year we spent 40 billion. So if you go to Malaysian level, we need to add additional 84 billion US dollars. So it will be triple the number that we are spending. If we compare to Singapore, 84 years average life, one of the most efficient in the country, 3,300 US. It will be 3,000 US difference. So if we go to Singapore level in the next 15 years, 20 years, we will increase 3,000 per capita, multiplied by 280 million, it will be 840 billion US dollars spending needed. Half of the Indonesian GDP now. You're talking about Singapore, the most efficient. Japan is less efficient than Singapore. They reach the same level, average life 84, but they need to spend 5,500. If you go to US, it will be even crazier. US is only 79, the average life. They spend 11,900 per capita per annum. So if we don't fix the system properly right now, then in the next 5 to 10 years, definitely the health minister is not me, definitely the finance minister is not Ibu Sri Mulyani, but Indonesia will have to carry huge burden as a country, just to support the healthy lives of our people. So that should be a challenge. And when I see what is the difference between Singapore, Japan, and United States, very, very clear. Country that focus on promotive and preventive, the spending is much less than country that focus on curative. You wait until you're sick and then you cure them. That will be bloody expensive. That's why our strategy at the beginning, we are very focused on screening, because that will massively reduce the future outlay of this healthcare expenditure will become politically extremely sensitive. So that is the first problem. The second problem, this is unsustainable. Why? Because the average increase is 11% every year, 13% expenses, healthcare expenses of the country. Our country only grow by 5% to 6%. So the expenses is always bigger than the income. If you are running a family, your family, if you as a husband, your income is only grow by 5%, and if your family expenditure, your kids and your wife asking for 11%, 12% increase every year, forget it. It will be unsustainable. So we need to do something in managing these expenses to make sure that it's sustainable. It's close to GDP growth per capita, because otherwise it is not sustainable. One of the biggest problems in this industry is the intransparency. I came from finance. So if we want to do financial product or services, the price is roughly consistent across the world. If you want to exchange US dollar to rupiah, you want to change that in Citibank branch office in New York, or you want to change that at Narita Airport in Tokyo, change that in Bank Mandiri ATM, the exchange rate is about the same. But in healthcare services, you're talking about multiples, 100%, sometimes 1,000% difference. When you want to do a certain procedures at appendicitis in Indonesia, even the clinic and the private hospital, the difference of price can be 500%. You go to Singapore, maybe increase to 1,000%. So in healthcare, the asymmetrical informations about quality of service and pricing hinder, difficult for us to control the increase on this pricing. So that's why it comes to the third problem, which is also part of the solutions of the issue, which is the third problem is our insurance portion is too small. The red one is the national insurance scheme, is only 27%, and above it is the private insurance scheme, even smaller, only 5%. So the insurance component that funding this 40 billion expenditure is only around 30%. Why insurance is very important in my personal view as a banker? First, insurance is the only power that can push back the inflation pressure from the provider. BPJS, our national insurance scheme, is the only legitimate power that can push back the cost of the hospital, the cost of the medical doctors, the cost of the pharmaceutical company to charge the client. Because the client in this situation in healthcare sector, it's very difficult to argue and bargain if they are being charged excessively or if price increase excessively. So national insurance scheme being hated by the hospitals, by the pharmacists, by the medical doctors, but they play a very significant role to push back. So the increase in the cost will not, excessive and below the increase of our income to make it sustainable. The second importance of the life insurance is then we can spread the cash flow risk because you need 40 billion cash flow every year. It's a big amount of cash flow. Insurance is a delicate financial instrument that can spread the cash flow risk across population because we have 280 million population, not 100% will sick at the same time. So the healthy population can subsidize the sick populations and also can spread the cash flow risk across time. Because some people, when they are young, they will be healthier. When you are getting old, you will be sicker. So then the young people will subsidize also the old people. So this is the importance of the insurance. That is our intention to increase strategically our insurance coverage in terms of healthcare financing up to 80 or 90% of this. Reduce the out-of-pocket, reduce the individual's negotiations, and dominate with insurance scheme. And I would like to limit, the private insurance between 20 to 30%, because in our experience, looking at developed countries, including the US, when the private insurance component is so big, the conflict interest is much bigger. So they can strike a deal with the healthcare providers, and that is not the benefit of the people. So I strongly believe still the government still need to play a role here. So this is some of the program that we are doing. On the next slide, we are combining the benefit between the national health insurance and the private sector to make sure it can grow faster. On the next slide, we also improving the way we are designing the diagnosis, the disease risk group. Before we are using the template, now we are using the Indonesian system that hopefully we can run. And the last one also, we make sure that our national insurance system is not only covering the curative side, but also the promotive and preventive, and hopefully later on the palliative and restorative mode to serve our people. So, ladies and gentlemen, those are the things that we would like to do, and hopefully that this will the Indonesian experience can be shared and discussed and debated. And we wish you all the best meeting in Bali. Thank you.
Thanks so much, Pak Budi.